Good afternoon, everyone. Thank you for joining us for today's Lead Center webinar, Promoting Leadership, Effective Strategies for Integrating Employment Outcomes and Services into Managed Care Models. My name is Elizabeth Jennings. I'm going to be your facilitator today. I'm also the Assistant Project Director of the Lead Center and invite you, if at any time after today's webinar you have questions or you'd like more information, please feel free to email me. My email address is jenings@ndi-inc.org. We're so pleased to have you with us today. We're also thrilled to have with us our presenter, Lisa Mills. She's a systems and policy consultant. She's also a Lead Center subject matter expert, and we're very pleased that she was able to join us here today. In case you haven't joined us before, the National Center on Leadership for the Employment and Economic Advancement of People with Disabilities, commonly called the Lead Center, is a collaborative of disability, workforce, and economic empowerment organizations led by National Disability Institute with funding from the U.S. Department of Labor's Office of Disability Employment Policy. We have already heard from our partners at the Office of Disability Employment Policy that they're experiencing technical difficulties. We're going to invite them to do a welcome as soon as they're able to join. I'd now like to invite my colleague, Nakia Matthews, to offer a few housekeeping tips.
Good afternoon, everyone. The audio for today's webinar is being broadcast through your computer. Please make sure your speakers are turned on or your headphones are plugged in. You can control the audio broadcast via the audio broadcast panel, which you see below. And if you accidentally close this panel or if the sound becomes unintelligible, you can close and reopen it by going to the top menu item, Communicate, Join Audio Broadcast. If you do not have sound capabilities on your computer or you prefer to listen by phone, you can dial the number and meeting code that you see here, and I will also paste this into the chat box for everyone. Real-time captioning is provided during this webinar. The captions can be found in the Media Viewer panel, which appears in the lower right-hand corner of the webinar platform. If you'd like to make the Media Viewer panel larger, you can do so by minimizing some of the other panels like Chat, Q&A, and Participants. And conversely, if you do not need the captions, you can minimize the media.
We seem to have momentarily lost Nakia, so if you would like to submit questions, please use the chat box or the Q&A box to send any questions you have during the webinar to Nakia Matthews or to myself, Elizabeth Jennings, and we will direct the questions accordingly during the Q&A portion. If you are listening by phone and not logged into the webinar, you may also ask questions by emailing them to me, Elizabeth Jennings, at ejennings@ndi-inc.org. This webinar is being recorded and the materials will be placed on the Lead Center website. We've offered that link for you there, and we will also provide it again at the end of the webinar. As you can see, having your questions answered today is very important to us, so please don't hesitate to submit questions anytime you have them. We'll hold them until the end, but we will do our best to make sure that your questions are answered either today before we wrap up or via email after the event. If you experience any technical difficulties during the webinar, please use the chat box to send a message to the host, Nakia Matthews, or you can also email Nakia at nmatthews@ndi-inc.org. The Lead Center mission is to advance sustainable individual and systems level change that results in improved, competitive, integrated employment and economic self-sufficiency outcomes for individuals across the spectrum of disability. We seek to do this through both individual level change and systems level change, and many of our webinars have focused on the individual level, and these last two have focused on systems level change. So we're very excited to have you join us today. Today we're going to talk about the emergence of Medicaid-managed long-term care for people with disabilities, including reasons for its use, general principles of managed care and how a focus on integrated employment at competitive wages fits well, variety of strategies for embedding integrated employment as a priority focus in assessment, planning, resource allocation, service delivery, and quality management. I'd now like to invite our speaker, Lisa Mills, to provide you with further information. Thank you, Lisa, so much for joining us. And Lisa, I believe you may be on mute.
Can you hear me now?
I can, thank you.
Okay, thank you. Sorry about that.
Problem.
Thank you, everyone, for joining today. My name is Lisa Mills, and I am a consultant with the LEAD Center. I'm from the state of Wisconsin, and for 7 years, I worked with the Department of Health Services on integrating a focus on integrated competitive employment into the state's managed long-term care system, which is called family care. So I now work with a variety of states through the LEAD Center and through the ODEP Employment First initiative. So we're talking today about the importance of integrating employment into managed long-term care. As you probably are aware, many states are either in the process of transitioning their long-term care system to managed care, or studying the possibility of doing it, or are already have completed the transition. And the real focus, obviously, is because states face increasing budget constraints that are really impacting the Medicaid budget. They're seeing escalating costs, at the same time growing waiting lists across long-term care populations as older folks, the baby boomers, retire, and between them and individuals with disabilities, we know some states have waiting lists that are very, very large, and in some cases almost as large as the number of people they're actually able to serve. There is also growing evidence now that managed care is a viable strategy to lower costs in long-term care, with the focus also on increasing quality. The real gold standard for managed care is that it is able to lower costs while also producing higher quality. The other advantage of long-term care, I think, from a state agency's perspective, is that they can contract out responsibility and risk in a capitated model for administering long-term care services. That does not absolve them of overall responsibility for the system, for quality, for compliance with all federal regulations, and for establishing policy. But it does allow them to partner with managed care organizations that shoulder the risk around meeting long-term care needs. I mentioned a little bit about the growth of managed care. The late 1990s, when Wisconsin started, a few states, in addition to Wisconsin, began exploring how to apply the principle of managed health care to the provision of long-term care. Wisconsin started planning in the late 90s and then piloted the model from 2000 to 2005, and then evaluated it, and at that point the legislature and state administration made the decision to go forward with statewide conversion. I will mention that we're now nearly 15 years down the road, and Wisconsin has not yet completed the full statewide conversion to managed long-term care, but that has mostly been to do with lack of state funding recently to expand the managed care model, because built into the Wisconsin model is eliminating waiting lists. So when they move managed care into a given area, there's a 3-year time period for eliminating waiting lists, and that requires new state money. But between 2004 and 2012, we saw it 16 states actually become involved in managed long-term care, and the number of people during that period increasing to nearly 400,000 in the country. And recently there have been articles and papers written about the numbers of states, of other states that are now moving in this direction. The National Council on Disability, if you are aware, has weighed in on the dramatic expansion of managed long-term care. They've done some studies. They put out some recommendations that are very, very important, especially with regard to employment. They talk about that they do believe that managed care offers opportunities to improve quality and cost effectiveness if it has strong oversight and planning. They make the point that working age adults, and I want to clarify here when I use that terminology, working age is trending well past 65 now, and when we think about the front end, we're talking about youth as young as 16. They say that employment is a critical pathway to independence and community integration. I'm sure most people on this call recognize that. And they said it's vital that managed care offers supports for people to obtain and maintain competitive integrated employment, meaning employment paid at competitive wage, which is always at least minimum. The center, CMS, they asked, this was in March, they put this, a large paper out, asked CMS to prepare and release a written protocol outlining the criteria they would use to evaluate states' applications to do managed care. And they suggested a lot of these elements and conditions were not necessarily being paid enough attention to, and that CMS should put forward a very clear communication to states that the indicators for success would be looked at when they apply. Sometimes people say government takes a long time to act, but in this case, just 2 months later, CMS released a summary of essential elements on managed long-term services and supports, did exactly what NCD recommended. And in that paper, there were two very important points around employment, that the services should be delivered in a way that provides the greatest opportunity for community and workforce participation, and that CMS expects that states will have adequate capacity and expertise to provide access to services and supports that would aid community integration, and they say such as employment supports. So again, this follows on the heels of CMS's September 2011 guidance about the importance of employment for working age individuals who participate in Medicaid services, Medicaid waivers. The principles of managed care, I'm sure a lot of people have their own set of principles. For me, this is what I've learned about what the principles are. The first is the right service in the right amount at the right time, so that we are taking a very close look at what people actually need, what goals they want to accomplish, and what service makes the most sense to help them get there, rather than simply going through a planning process where we look at people and if they look like others that we already serve, we talk about offering them the same services that everyone else has. Service authorizations are in managed care are certainly done with the intent to control costs. So there is an attention to not over-supporting people. In other words, not giving people 6 hours a day or 5 days a week if in fact they don't need that much support, or looking at how they can rely on natural supports to the greatest extent possible. Sometimes people look upon that rather negatively, but in fact in the developmental disability world, helping people develop natural supports and community building has been a very strong principle. So we're now applying that in an approach that's designed to help reduce the need for paid supports. Also using the lowest cost service that can meet a person's needs, and thinking about what kind of support people need at a given time and whether or not there are ways to meet that support with a low-cost service. One example would be not putting a job coach into an employment situation where somebody simply needs some personal assistance or personal care, and trying to think about authorizations in that way. Another great principle of managed care is investing in low-cost preventative services to reduce higher costs down the road. Some examples would be to help people remain with their family so that they do not need residential services. Another example, on the health side, we've done a lot of this since managed care has grown out of the healthcare field, but managing diabetes, getting a flu shot, going to the dentist for regular checkups, all are short-term investments that result in significant longer-term savings and, of course, significantly better health for people. And then the last thing, I think managed care allows for a lot broader flexibility in who can be paid and what they can be paid for. Even though there is a provider network, there is more flexibility in being able to pay whoever it makes the most sense to deliver the support to someone. MCOs basically contract with a network of providers who are willing to accept their rates and meet their quality standards. The rates still must be adequate to ensure adequate provider capacity and choice of provider for people participating. And the last thing I think managed care does is it really shifts the focus to outcomes of services as opposed to receiving a service as an end in and of itself. So it really asks the question, what outcome do we expect from this service? What does the person want to achieve? And helping providers focus on the outcomes that they can help people achieve. The case for integrated employment in managed care, for me, it's obvious, but many folks involved in managed care don't necessarily come from the employment world or even the disability world, and I think we need to be strong advocates for the case for employment being fully included in any managed long-term care model. There's excellent research out there showing that there's a bidirectional relationship between employment and health, meaning that employment contributes to better health and better health contributes to participation in employment. Better health equals lower costs for managed care. There's a body of research, of course, that shows employment contributes to the prevention of and the recovery from mental illness. And we know in Wisconsin, for example, managed care is for individuals with physical disabilities and intellectual disabilities, yet we know that a very high percentage of those people also have co-occurring mental illness. And so even if the primary disability group is not individuals with mental illness, this is very, very relevant. There is some research out there that says if you participated in integrated employment, you maintain and develop greater skills for activities of daily living. It's common sense in a way, but those skills go directly to reducing the other kinds of supports that you might need on a daily basis. You basically remain more independent. Another big piece is that employment creates opportunities to build and use natural supports. If you are in community with others, you can develop natural supports. If you are in a segregated setting or a medical setting, you are surrounded by paid people, and there is virtually no opportunity to develop natural supports that you could rely on and that could reduce your need for paid supports. Of course, employment enhances income. We've done an awful lot to create meaningful work incentives in Medicaid and with Social Security to help people be able to earn good money and still keep their eligibility for services. And one of the things that, is a reality with that is that people can contribute then in a copay arrangement to the costs of their supports. Some people resist that and don't like that, but in reality, other people say they don't mind contributing if they are able to. And so this is one of the ways that employment can help spread service dollars further. Also, the most important thing is employment offers access to employer-sponsored health care. And again, if we shoot high in terms of hours worked, and when we help people obtain employment, we can get a lot more people accessing employer-sponsored health care, which of course is incredibly important for controlling Medicaid costs. So all in all, employment yields very big dividends and should not be left out of any valid managed care model. Unfortunately, however, where we've come from is a system that has invested most of its resources in supporting people in unemployment and poverty. We have assumed that people will not work and that they will live in poverty. And as a result, we have invested most of our money in supporting those outcomes. Managed care creates an opportunity to really make a shift in how we invest in people and to really prioritize employment outcomes for people. The different ways that this is based on my experience and thoughts about this, the ways to embed employment in managed long-term care are many, and it's very important to think across the system, across the model, of all the different ways that integrated employment can be embedded in the approach. Most importantly, employment must be a stated and desired outcome of managed care from day one. It is very difficult to go back after you've had a managed care program in place and try to add in a focus on employment. It is much more effective to start from day one and say that employment outcomes, competitive integrated employment outcomes, are a goal of managed care. And what goes with that is making integrated employment a performance measurement and having managed care organizations report data annually as they report data on other things, like how many people got a flu shot or how many people went to the dentist or case management turnover, these other things that we identify as critical. Integrated employment participation has to be one of them. The other strategy that's available under managed care is pay for performance, and we have seen some states have started to use this for employment. I think it should be required that every state look at how they can use pay for performance to develop better integrated employment outcomes. That model essentially rewards the managed care organizations with bonus payments that they can earn based on improving integrated employment outcomes. And then there's something called a performance improvement project. States may have other names for this, but essentially there's an ongoing quality improvement process in every managed care framework. MCOs are typically required to focus on improving areas where they believe they're not performing well. And this is a perfect opportunity where where managed care programs are serving working age adults, that they look on a regular routine basis at performance improvement projects related to employment. Something that's critically important is how integrated employment is addressed in the contract between the state and the managed care organization. There must be clear enforceable language, and I refer to it as employment first language. That's the broad-based philosophy of making sure employment is an available option for everyone in the system. There must be very clear language in the contract that is enforceable, and it needs to appear throughout the contract so that in every aspect of the MCO's operation, integrated employment is being addressed. Managed care organizations are typically evaluated by what they call external quality review organizations, or EQROs. That group has to be well-versed on integrated employment and strategies that work and how to measure an MCO's performance, and it must be part of what they do. Unfortunately, because a lot of this model has grown out of the healthcare system, it sometimes lacks an appropriate focus on employment, and that would have to be built into what an EQRO does, or they might otherwise overlook it. And as well, the quality management strategy that the MCO must propose and implement as part of their contract must have a strong focus on integrated employment. I believe that states should collect and publish data on MCO performance around integrated employment. In most states, we're seeing models where there are multiple MCOs available for people to choose from, and working-age adults, people with disabilities, need to be able to see what each MCO's performance is on integrated employment so they can decide or factor that into their decision about which MCO they want to enroll with. The critical thing in terms of rate setting and determining eligibility for participation in managed care is the assessment or the screen that is used. And many times the screen that determines eligibility is also used to develop the capitated rates. If this does not have adequate sections in it to address integrated employment supports, there would be a problem in terms of the capitated rates that are set. We need to adequately address that, and again, a lot of the functional type long-term care screens and assessments have traditionally not addressed employment well enough. So it requires new approaches, new work to adequately include employment in those things. There are other parts of the typical assessment that can contribute to understanding accurately a person's need for integrated employment. You can build questions into how you evaluate a person's transportation needs and personal care needs and other things that will help inform the screen in terms of what do people need for employment supports. And there is also the issue where people who can be quite able in terms of the way that we look at functional abilities, but have some major challenges with regard to going to work. And one of them is criminal history. Another one might be a line-of-sight supervision court order. Things like this that have to be factored in order to adequately support people. Sometimes our functional assessments are not enough to accurately determine the amount of support someone might need. A critical part of all of making all of this work in practice is what case management staff do in a managed care model. One way to ensure that they are up to speed on employment is to establish in contract that employment is a core competency. That will trigger the MCO's attention to making sure they have adequate training. Again, many of these folks in states came from the old system, and we know the old Medicaid waivers most states did not have a strong focus on employment. In some cases, certain waivers did not even include any employment services, and case managers tend to have very little experience with people actually in integrated employment that they can draw on. So there needs to be active and focused training of case management staff, and a certain level of core competency has to be required. They have to understand why employment is important. how to address it in planning, what services are available, what other systems can help, and what role they are expected to play throughout what I call the person's employment life cycle, which starts all the way back from the first time you say, do you think you'd like to work, all the way through to career advancement and hopefully retirement. In one MCO I know about, they had such a strong desire to improve integrated employment outcomes and that focus that they implemented a performance-based salary adjustment. So when case managers went through performance reviews, if they had a certain number of people on their caseload who were in integrated employment, who were actively being supported in integrated employment, that led to a salary adjustment. And that, to me, is a very a pay-for-performance strategy that we should seriously be thinking about. Embedding also, I think, the comprehensive assessment, which is typically the first step in enrolling in managed care. It leads to the individual plan of care. We've seen some examples where that assessment has not adequately addressed employment, and as a result, the individual plan of care has not included employment. So we know we have to get the assessment piece right. In many cases, I've seen assessments where there was just a little checkbox that said, do you want to work or not? Are you working now? And that was about it. And if people said, I don't want to work, nothing else was done. And essentially, the care plan then went forward without any conversation about employment. So really what needs to happen in a comprehensive assessment with a working age individual is that there needs to be a deeper conversation with people that helps understand what their past experience or history or education is, what the reasons are if they say they're not interested in employment, so that we can actually actively address those in the plan of care and in case management. What concerns they may have that we'll have to keep in mind as we help them move forward with employment. And some real discussion about what are people's employment goals. Of course, these can change and people can change, but at least initially, how many hours would they like to work and how much income would they really need, and what would they do with that income? I think it's critically important that we approach the assessment conversation in a way that's very positive and oriented towards people pursuing employment. I do think in some cases that provider conflict of interest has to be considered in the plan process. We've had a long history of interdisciplinary team approach, but we have to think about when people express a desire to make a change in their life, how that impacts the provider, and that the provider may, have an inevitable conflict of interest in terms of perhaps wanting the person to remain in the existing services rather than make a change. And I think it's something that we have to be acutely aware of as managed care helps people think about changes they want to make. One of the most important things, of course, even after you do all this, is if someone says, I want to work, I want help to work, or I have a job and I need help to keep it, are the services available in the benefit package for the managed care system that can be authorized and help people keep work? And so it's extremely important as managed care is rolled out that a close look is taken at what services the MCOs plan to offer. And we know now from new guidance from CMS that they are encouraging states to offer services that can support integrated competitive employment. We know that benefits counseling can be included in a waiver as a covered service. Supported employment is now, CMS has made it clear that it's not just for people with intellectual and developmental disabilities, but any waiver eligible population can receive that service. And I actually know in Wisconsin that it's one benefit package across elderly, physical disability, and developmental disability. And we have people who are elderly who are receiving supported employment services, and a great increase in the number of people with physical disabilities receiving that service since managed care kind of leveled the playing field in terms of what services are available. Another critical service is workplace personal care and assistance. Many states under their state plan only cover personal care in the home. Managed care offers the opportunity to put this service in and allow it to be provided in the workplace. Again, it's not about dollars. It's not about if we put this service in, we're going to spend more. It's actually strategically having good services in the package so you can give people the right service at the right time and the right amount. And certainly having that in your package can save money when people don't actually need a more sophisticated job coaching service. Non-medical transportation is critical. We know that one of the big challenges for people is getting to work, and so we need to be able to ensure that transportation is available. It is recommended it not be attached to other services because that creates an unlevel playing field in that certain services have transportation included and certain services do not. And unfortunately, it's often the case that integrated employment supports don't come with transportation. So we want to make sure it's available, but that it's equitably available regardless, so that if I choose to work at a regular job, I can get transportation if I need it just as easily as someone who maybe doesn't choose that. Durable medical equipment is important, and so is assistive technology. Again, just making sure these definitions include references to supporting people in employment. And as well, under the broad service categories that we have under in the benefit package, making sure best practices are clearly named as things that can be covered. So under supported employment, we're always recommending customized employment, including discovery be covered, individual placement and support, the IPS model, and self-employment would be three cutting-edge strategies ODEP's been involved in promoting and partnering with other agencies to develop, and these need to be specifically mentioned as fundable under the broad category of supported employment. Again, as I mentioned earlier, the services for employment should be available to all working age people regardless of disability, should not be limited just to people in one disability category. I find that people with physical disabilities usually get the short end of the stick, and oftentimes we don't see employment services in the package that's available to them. I'm also acutely aware about service limitations. Of course, states can establish limitations on services. We must be very sensitive to the fact that we aren't discouraging working in full employment enough so that people can access employer-sponsored health care and hopefully can then help contribute to the cost of their care because their income is high enough. Sometimes we can put service limitations in place thinking that we're saving money when if you are actually preventing somebody moving to employer-sponsored health care or contributing to the cost of your care, you're actually you're spending more. Non-work services, in a model where we're promoting employment as a priority outcome, every state is going to include or probably include non-work services, but they should really be promoted as employment wraparound, not as an alternative to employment for working age adults. So these services are in place to provide wraparound support to someone who perhaps works part-time if they need that wraparound support. another opportunity in managed care with the focus on outcomes and the pay for performance, the ability to pay for outcomes as opposed to services is much greater in managed care, and it offers a great opportunity around employment services because we've seen in the past that actually paying for service, the best high-quality employment service providers lose money for doing a great job, and the poorest providers actually are the ones who end up netting the most money in a fee-for-service model. So managed care allows us to fix those upside-down incentives and pay for outcomes, and the thing that I'm most interested in and most excited about is the idea that we can pay for a payment based on every hour the person works. So we are incentivizing the fading of paid supports, the engagement of natural supports in the workplace, and we're also incentivizing job development efforts that get people jobs at the highest number of hours and get them paid time off because the provider will be rewarded in that kind of outcome-based payment system for all those outcomes, which we have long said those are the most desirable outcomes for employment services, but we've paid them fee for service, and we've actually kind of said, and if you do that, we're going to cut your funding. So we have a great opportunity to fix that problem. Some people will say to me, well, it has to be simple. Any reimbursement model has to be simple. And I guess I don't think it's a debate between simple and complex. I think that the model has to be sophisticated enough to create the right incentives across people at a variety of support needs and with a variety of challenges to employment. We can't have a model that only incentivizes serving people who have the least challenges to work. We have to have a model that incentivizes serving everyone. Another opportunity in managed care with this ability to pay differently is that they can think about who's the most logical person or organization to support this person in employment and pay those people. So transportation can be more flexible in terms of if it makes more sense to pay a family member to make sure they can have gas in the car, or pay a neighbor or coworker to give somebody a ride to work, or buy them a bus pass or a taxi voucher, they can do that. And in the old system, that was much harder to do. So that is one way that savings can be realized in terms of people being able to be supported to get to work with a lot less investment than if we had to pay for a formal provider. The other thing we're recognizing in supported employment is that employers and coworkers can be really good supports for people. And sometimes the level of support people need exceeds what is typically a natural support. And whereas in the old system we would put a job coach in, we're now seeing models developing out of managed care where coworkers and employers can be compensated for providing the supports that people need and at a much lower cost. As I mentioned, also family, neighbors, coworkers, and providing transportation. In any managed care model, members should have the option to self-direct their employment supports. That's some of the way you can allow the payment of the best, most appropriately placed person. It allows being able to pay individuals as opposed to agencies where that makes sense. So self-direction is a key part of any successful managed care approach. MCOs should also be supported to become employment networks under Ticket to Work. They are providing services. They can help people reach milestones. They can take the ticket after if someone goes through voc rehab. There is still in many cases, money to be claimed milestones after voc rehab. My only caution there is I think there needs to be a fair agreement with employment service providers who are being paid by the MCO to deliver the employment services. They need to share in the wealth of captured ticket to work payments, because sometimes you'll encounter a situation where the MCO is an EN and so is the contracted provider, and that creates a bit of a rub around who's going to benefit from this ticket money. I think the best way to do it is to actually have an agreement in place. Also, I think as part of contract, states that are thinking about this and intending to embed employment in managed care and improve integrated employment outcomes should require from the very early establishment of the MCOs that they enter into an MOU with their VR regional offices who serve their area, that MOU specify how they will serve common customers, how cost sharing will go on, how there will be effective handoff of a person between systems, you know, all of the issues that come up in terms of referrals and commitments to serve and provide long-term support. All of these things need to be addressed up front in an MOU, and it shows good faith on the part of the MCO to work effectively with the voc rehab system to serve its members. Oftentimes there are state-level MOUs between Medicaid and VR around employment and services to common customers. That's a good model for all the MCOs to follow. Of course, nothing should be inconsistent between a local MCO MOU and a state-level one, but really MCOs need to have their own relationship and their own MOU with VR for it to work best. Going along with that, as we think about transition age youth and the idea of supporting youth to leave school and go directly into employment or post-secondary ed, MCOs should be required to enter into MOUs with local school districts who are in their area. Again, it should include the same kind of detail of how they will work together. Many students will remain in school past age 18, and in states that implement managed care with the intent to eliminate waiting lists, which frankly I think should be a condition of any state's the approval of any state's move to managed care. But if states have a commitment to eliminating waiting lists, we, like Wisconsin, we get to a point where managed care has been in an area for a certain period of time, there are no waiting lists. So an 18-year-old who's still enrolled in school can also have a managed care plan. And there's an opportunity then to jointly serve the person and to involve voc rehab as well. So I do know some youth who have an IEP from the school, an IPE with VR, and a managed care plan of care with the managed care organization. And all three systems can share responsibility for supports. But a good MOU really lays the groundwork for that happening in practice. And as I said, again, it should be from day one that MCOs are expected to enter into those MOUs. My cautions around managed care, just some from personal experience. Managed long-term care is evolving from healthcare, and there is a strong risk of returning to a medical model, of having the model be too focused on medical outcomes. Now, most new managed care approaches are obviously combining acute and long-term care and having that delivered in an integrated way. I think that we've seen fairly good outcomes with that because you talk about the long-term care side investing in employment and the MCO realizing the savings that come about because people have better health, because they are also managing their health care. But I think we have to constantly pay attention to not medicalizing long-term support for people with disabilities. And that's tough to do in a Medicaid system, I acknowledge that. The other thing I think is lack of expertise around disability. Many of what's driving managed care includes a desire to effectively serve elderly people, and in some cases that becomes such a predominant focus that a lot of people involved in rolling out new managed care don't have the real strong knowledge around serving people with disabilities and what independent living principles and self-determination principles really mean when you translate them into a managed care framework. And again, Wisconsin is one example of creating a single managed care system that serves elderly people as well as people with disabilities. And I think it's very tough to keep the focus on outcomes for people with disabilities, because the sheer number of people, of older people who enter the system, even though they stay for a much shorter period of time, means at any given time you've got a huge percentage of people are going to be elderly, much smaller percentage going to be people with disabilities, although those folks spend many, many more years enrolled. This is nothing new. It's been talked about an awful lot lately. Rapid implementation of managed care it creates poor transitions for people served. And, Wisconsin, I guess, ends up ultimately being a model for the country in terms of rolling it out slowly for various reasons. It's 15 years on, and we haven't yet finished. But they did a 5-year pilot before they made a decision to go statewide. And I know other states are under extreme budgetary pressures and want to realize savings quickly, but we have to find a way to balance that with ensuring good transitions for people and good outcomes. My other concern about managed care is if there's two goals, better quality and lower cost. If we get too focused on lower cost, we will see implementation that I think is just really crude in terms of going at reducing services, reducing reimbursement rates to providers, and not thinking about all the other strategies I talked about earlier about how you make sure people get the right amount of service at the right time, and that you make sure you're developing more cost-effective ways to deliver service to people. So you simply aren't saying, we're just going to give you less and we're going to pay the providers less. And then I think we still, in any managed care model, so much more attention to cost and spending. And supported employment, we have to work really hard to make sure people understand accurately that supported employment is a cost-effective service. Again, because we typically pay for it on a fee-for-service basis, it appears much more expensive than alternative services. And if we don't do good education of managers and case managers in managed care, that attitude, that belief will continue. And I do believe that people will not be offered supported employment, be discouraged in planning and assessment because of the perception that it costs more. So I'm not sure who all is out there and what your role is. I hope this was helpful. But I think if you are not in charge of rolling out managed care, some of the most important things you can do right now is ask questions. Ask them in writing. Keep asking them as early on in your state's process of developing managed care as you can get. How will integrated competitive employment be addressed, and ask different questions. How will they address it in rate setting? How will it be addressed in contracts? Contracts should be public documents. You should be able to see them. I'm not saying they're a fun read, but you should be able to see what is proposed language for contracts. What is the assessment process? How will it address employment? How will care planning and the development of plans of service address employment? Very, very important, what services will be included in the benefit package that can be used to support integrated employment, and looking at the proposed definitions for those services to make sure it's clear and best practices are included. How will they measure performance around MCOs and integrated employment participation of members? If it isn't measured, I'm sorry, it's a cliche, but it will not get done. It will not get attention, and typically we're starting out with very low rates of participation in integrated employment. It has to be measured. There has to be performance targets for improvement. Quality assurance has to pay attention to this, and how are they thinking about using pay for performance around employment instead of just limiting that to health issues or health strategies. As I always say to people, the devil's in the detail. Managed care that says, yes, we will improve employment, yes, we care about employment, and it only matters if you can see it embedded in the model in all those ways that I've talked about. And I'm stealing from Assistant Secretary Martinez, who she was talking about people with disabilities and the workforce investment system. She said they have to be baked in, not layered on top, and I would say that is absolutely true for integrated employment in a managed care model. It's got to be in there from day one. It's got to be embedded throughout the approach. One of the best ways to get the state to recognize the importance of it is to share all the rationales we have for how important employment is and what the payback is to them, how they will benefit, and how their goals can be met through helping more people work. And I'll just say that a lot of states, because they just haven't paid attention to integrated employment as much as we had wanted them to in the past, are now just becoming well-versed and aware of actually what makes a difference and what actually improves outcomes. And so they will want to, I'm assuming they'll want to hear from you, or they'll need to hear from you about what strategies they should be using. I will stop there, and there's a cartoon I found that I thought was rather interesting and something about the times we're facing. Although the doctor on the left, we could easily substitute a community service provider there. I will turn it back to Elizabeth.
Yep, thank you so much, Lisa. We really appreciate your presentation. A lot of good information, some of it new to many of the folks on the line, and there's been quite a few questions that have come in. So the first question kind of brings us back to the beginning, and the question is, can you please share what exactly you mean by long-term care?
Yes, I mean, what would traditionally have been thought of as a Medicaid waiver, long-term services and supports that help people live in the community, not health care, but other Medicaid fundable services that assist people with independent community living and work.
Great. Thank you. Our next question is, revisiting your comments around VR, can you please share a little bit more about how this works in combination with a state VR program? For example, if a referral to the VR system is a fulfillment of the MCO's duty under a state plan to provide, say, integrated competitive employment services to the individual, how does that work based upon VR being VR's comparable benefit rule that requires the individual to access generic resources first before the VR system can pay?
Well, interestingly, you know, Medicaid, and this applies to managed care, they have the same or similar language that says they are the payer of last resort. And I think at the end of the day, while we work very hard to try to get more federal guidance around these issues, Both systems have a role to play in serving individuals with disabilities. Individuals with disabilities who are eligible for Medicaid managed long-term care typically meet nursing home level of care. There are some models where you don't have to meet that, but they're typically people with the most significant level of disability, and that is also VR's priority group. And the reality is that people have a better experience and get better outcomes when both systems participate. And for me, the appropriate balancing of roles is that VR does what VR is able to do, which is the upfront services and supports to help a person obtain a job. And then when VR is no longer able to support a person to keep their job because they have limits and they can only provide supports for so long, that's when the appropriate role of a managed care organization really kicks in. And they pick up the responsibility for long-term supports. Both systems say you're supposed to go use the other system first, or we need to know the other system can't provide you supports before you come to us. And frankly, there's no answer to that right now because it's a contradiction. There's no clarity really, and I think what we have to remember at the end of the day is that the best outcomes result when each system plays a role. And that can be decided at the local level, at the state level, about how the systems will cost share and share responsibility. But typically, VR agencies have embraced that responsibility. I mean, it's getting, I think, the level of collaboration around employment first and improving outcomes is getting so much better that VR is beginning to see, this is part of who we're supposed to be serving. Obviously, more people than in the past are coming from the Medicaid system looking for help to find work. And so it actually helps when states sit down and say, what can you do and what can we do, and try to work that out.
Great, thank you, Lisa. The next question is, how does discovery fit into employment in managed care?
Discovery is, again, under supported employment or any kind of career planning service, discovery can be done. I think we're seeing more and more about long-term support, managed care saying, we will fund the initial phase of discovery for somebody. We will fund that as an exploration leading to a referral to VR, so that when people come to VR, they are much more prepared to engage in the VR process. And there's been some time spent helping them understand their strengths, their interests, and the conditions they need to succeed in integrated employment. So while VR can also pay for discovery, I've seen increasing investment on the Medicaid side and within managed care to support discovery as an activity designed to lead to a referral and an application to VR for people to get support to get a job. Mostly because of the focus on outcomes in managed care and because it makes sense, states have been paying for discovery either on an outcome basis, kind of mirroring the milestone payments that a VR system uses, or in some cases on an hourly basis, but with tiers according to how much of an intensive process does each person need.
Along those lines, I just want to advise anyone who's on the line that if they are not sure about group discovery, that's a new term for you, then I want to invite you to visit the Lead Center archives, and I'll ask Nakia Matthews if she could put that link into the chat box now. We've provided some webinars on group discovery and customized employment, and if you're new to that topic, those webinars can be a great resource for you. Lisa, our next question is, Texas has had managed care for long-term care for years, and is just now bringing Employment First into the program. Any tips for helping to change the vision and make this into an existing plan?
Yeah, well, obviously you've probably gathered from my prior comments that I think that's a really tough challenge. Not that it shouldn't be done and that we can't achieve the same outcomes, but retroactively inserting employment is tough. One of the most important things I think is that case managers need retraining. They really need retraining because they need to change the way they approach individual planning and the identification of people's outcomes. Also, they would need to really have a good look at the services they have in their benefit package and whether they need to add services or enhance any services that they have, so that it's very clear how this new focus on employment is going to be supported through changes in service plans. I mean, if people's service plans don't change, if the conversation at the planning table doesn't change, outcomes won't change. I also believe they need to take a good look at reimbursement rates and reimbursement methodology. They don't necessarily have to spend more, but they may want to change the way they spend and enhance spending or enhance some of the rates and incentive payments around integrated employment, and perhaps reduce some of the payments they may be making for other services to make sure that providers see a real clear incentive to go in the direction of expanding integrated employment services. I think a great way to do it, though, if I were doing it, is either a pay-for-performance initiative or what I refer to as the performance improvement plan, to coordinate a statewide performance improvement effort around integrated employment. It would allow managed care entities to have a dedicated focus to changing this. If you don't do that and you simply say, yes, we're going to embed employment, I fear that the outcome really wouldn't be what people were hoping.
Lisa, now might be a good time for one of the questions that was asked. It asks, when you say case managers, can you please clarify which entity such case managers belong to?
Yes, when I use that term, I'm thinking about the managed care organization, that the organization that receives the capitated payments and is responsible for service plans. The case managers, they're called care managers, they may be called other things, are the people employed to do individual plans of care and service plans with people and monitor that over time. So they do the authorizations of if people are going to get employment services, it happens through them.
Thank you. Another clarifying question is, how is this different from Medicaid waiver services that are provided in my state?
It shouldn't be that different, except that it's done through a managed care model. So instead of fee-for-service, where the state is essentially on the hook for whatever services are authorized and planned, this creates the managed care approach. Creates an intermediary where the state caps the payments that it makes to the MCO based on the number of people they're serving and their functional needs, and it's up to the MCOs then to ration those resources and meet each individual's needs. So in a sense, it doesn't always feel that different to the service recipient, but it's a very different way of approaching the financing of long-term care.
And actually, I feel a bit connected to that response. The next question is, what do you see as the principal driver to reducing or eliminating a state's waiting list when long-term supports and services are moved to managed care organizations?
The principal driver would be, well, a requirement, and I mean, I'm going to go so far as to say that CMS makes as a condition of the state having its managed care waiver approved, having approval to transition its system to managed care, that it will commit to eliminating the waiting list, and therefore it will commit to using some of the savings, if not all of the savings, that result from moving people into managed care, to reinvest in taking people off of waiting lists. Now, in some cases, that's not, using the savings alone is not enough money, depending on the size of the waiting list. But at the very least, the expectation that savings, or a decent portion of the savings realized by managed care, should go to the waiting list. Otherwise, I'm not sure how you, in the short term or in any reasonable time frame, you address the waiting list.
Fair enough. Thank you, Lisa. Another question is, can you offer some insight into how benefits counseling, especially through WIPA services, might interact with MCOs?
Yes, I think MCOs are always going to be looking for other generic resources that are out there before they're going to spend their dollars. And that's just one of the principles of how you make sure that you control costs. So they will, in all likelihood, want to refer people to WIPA for benefits counseling services. But I do think that MCOs who are focused on integrated employment will also want to include benefits counseling, some level of service in their benefit package in cases where the WIPA or services through VR or some other source are not available to the person. So it's an opportunity for WIPA providers, WIPA benefits counselors, to contract, to get a contract with a managed care organization to provide that service, so that they can expand the number of people they potentially provide benefits counseling to.
Excellent. We had a follow-up question from our friends in Texas who asked about helping to, that their state had been bringing Employment First into their managed care program. Their question is, are there good examples of reimbursements and incentive payment models for us to look at?
Yes, I believe there are. Of course, that's from my perspective, and I'd be more than happy to follow up with you and talk about that. I think we're learning a lot more about what good models are. Not that there's only one way to do it, but that a lot of history with supported employment and employment services is that hardly any people got them. So there wasn't a lot of attention paid to how we were paying or how cost-effective our model was, because it was such a small expenditure in the overall expending in long-term care that I'm not sure people paid much attention. But as we obviously go towards Employment First, and this improving these outcomes, getting so much more attention, and we're contemplating much larger numbers of people receiving these types of services, states have started to do a lot of intensive work around arriving at rate structures that make sense and reimbursement methodologies that really incentivize the outcomes. So I'd be more than happy to talk with you about the examples and the learning that's been going on.
Thank you, Lisa. Earlier in the presentation, you noted that there were individuals who were considered elderly who are working and receiving supported employment benefits through their managed care organization. When you say elderly, what age are you speaking of?
I'm pretty sure it's 65 and up. So that would be the criteria for having your target, your disability population, or your target population. And if you fell in elderly, you would be 65 or older.
Okay, thank you. One more question, Lisa. Given the health benefit of employment, why don't MCOs do this automatically?
Because because I think that information has not been well circulated. It has, back in 2006 and 2007 when I started working with the Wisconsin Department of Health Services, we started to make that assertion, and they, they said, well, we're not aware of any research that shows any of that. And so one of the first things we did was a literature review to begin to assemble this information in a way that would be convincing, because we knew that Medicaid, managed care, focused on health outcomes. And we knew if we couldn't make the link between being employed and better health, that we weren't going to get very far. But I think the problem has been that we have not become really well versed in that literature base. And in fact, I think there's a lot of research that still could be done that could contribute to our understanding of that could look at this specific population and say, for the people who are working, what are their Medicaid health costs, what are we spending, to try to even strengthen that argument. It's not too hard to make the argument once you start to make it, but a lot of times people who are focused on what is a health care program have not been thinking about employment and how that might have a bearing on health.
Thank you, and I apologize, I spoke too soon. We actually have one more question. You mentioned that folks should ask a lot of questions and speak about some of the things that they learned today to get some of this into the MCO contracts. This question is, who in my state is responsible for this work?
It depends on, every state's certain systems are organized differently. So the Medicaid agency and typically a partner policy agency, disability agency, would be responsible for the contracts. And I can't be any more specific than that. I think you have to do some research about the contracts and who issues them. So, for instance, I was looking at one from Kansas recently, and there were two state agencies that were jointly issuing those contracts, I think. So you need to find out where the managed care administrative arm of the state is located, and then you will find the people who deal with the contracts. And I'll just warn you that what they're working on right now is the contract probably for 2015. That's how far in advance you have to get engaged with them in terms of them, making changes to the contracts.
Excellent, thank you. I want to thank you so much, Lisa. This was excellent information, and there were a lot of questions today, so thank you to all of you out in the audience. If you have additional questions, please feel free to send them in. We still have a little bit of time. We're also willing to accept your questions via email. You can send them to myself, ejennings@ndi-inc.org. I'd now like to ask Nakia if she could make me the presenter again. Thank you. So I'd like to take a moment to invite our partners at the Office of Disability Employment Policy to share a few words.
Thank you, Elizabeth. I hope everyone can hear. I'm calling to my cell phone because we were having a bit of a technology problem here at ODEP today, but I think that those of us here in the ODEP room found this webinar absolutely incredibly informative and useful, and I want to really send just so much thanks to Lisa for doing an amazing job. We do have some follow-up questions, Elizabeth, that we're going to be submitting so that as a list of follow-up questions is pulled together, I think it's just going to be, a further opportunity to flesh out a few more of the comments. I think that some of the things that Lisa pointed out really emphasize to all of us how important it is that we be at the table and to educate people about the importance of including employment-related supports in the MCO contracting, and to kind of fix the misperception that exists around some of these services are more costly than alternatives, and therefore we shouldn't do them. And when you look at the gestalt, as Lisa has said, and the benefits of working and the lower costs associated, and et cetera, that we have a lot of fodder to bring to the table, a lot of important information that the MCOs do need. I want to harken back for just a moment to the question that someone asked on discovery, and I think, Lisa, you mentioned something about funding the initial phase of exploration that could lead to referral to VR. I want us to also remember to always think about the AJCs, the American Job Centers, and how they can be thought about as the MCO contracts are being organized as well, and the important role and the services that where a collaborative relationship might also be really critical for people with disabilities who are accessing services through an AJC, but who might not be going to VR for whatever reason. Anyway, Lisa, I just can't thank you enough. I thought the information was amazing. And to all of our colleagues at LEAD, Elizabeth and others, thank you so much for pulling this together. It was just really, really exceptional.
Thank you so much, Chris. And thank you to everyone who's on the line today. We are so thrilled that we're able to offer you these webinars every month. In fact, if this is your first time joining us, we provided a new webinar every month this year on the last Wednesday of the month from 3 to 4:30. We presented them as 3 mini-series, a series on economic advancement, a series on employment, and a series on leadership or public policy. We are offering the webinar archives for your use anytime you're available to view them. We're providing you with a list of all of the different webinars that we provided so that you can build your knowledge around these important issues related to the employment and economic advancement of individuals with disabilities. Today was our last webinar in this series on public policy. If you missed the one in August, that webinar is also available for you through the archives. We'd like to provide to you an overview of everything we've done this year and many of our outcomes. We're going to provide that through a webinar in October on the 23rd from 3 p.m. to 4:30 p.m. I hope you'll join us for the LEAD Center inaugural year in review. As I mentioned, we will be sharing outcomes of the LEAD Center's inaugural year, including some of our major accomplishments, emerging promising practices, and pending reports and knowledge translation. We've been so thrilled, again, to be able to offer you this series. If you would like to contact Lisa Mills after today, please feel free. Here's her contact information. And at any point in time, again, if you'd like to submit your questions to myself, Elizabeth Jennings, you can do so at ejennings@ndi-inc.org. A special thank you again to Lisa Mills for an excellent presentation today. Lots of things to think about for all of us, and some action steps that you can take in your own state to help integrate employment outcomes into long-term care services within managed care organizations. Thank you everyone for joining us today. Have a great day.